Hello and good morning. Welcome to the Wednesday morning rounds. Today, I'd like to introduce Dr. Annie Hung. She's a clinical fellow in our Advanced Heart Failure and Cardiac Transplant program. Very interesting topic, the donation after circulatory death has a great potential, I think, to increase the pool of donors. Thank you, Annie, and I'll leave the microphone to Annie now.
Thanks, Dr. Good morning, everyone. So my name is Annie Hung. I'm the Advanced Heart Failure and Cardiac Transplantation Fellow here at the Heart Institute. Thanks for taking the time out of your Wednesday morning to join me in person or online to learn about heart transplantation. My presentation today is titled Beyond Brain Death, the Rise of DCD in Heart Transplantation. So I have no financial disclosures, but I will be referring to various organ storage devices by their trade names. This is an outline for my presentation today. I'll briefly talk about the history of heart transplantation and how that has led us to the current state of heart transplantation. I'll describe how donation after brain death works, and then I'll dive into donation after circulatory death, or DCD, and then I'll talk about some of the early to medium-term outcome data that we have on donation after brain death versus donation after circulatory death. And so the history of heart transplantation. The first heart transplantation was done well over 50 years ago now. It was performed by a cardiac surgeon named Dr. Christian Barnard in South Africa. And in fact, it was actually donation after circulatory death. So in some ways, we've come full circle, but with a lot of interim developments. So what Dr. Barnard did was he transplanted the heart of a young accident victim into his patient, and he survived, but only for about 18 days. And as you can imagine, the early post-transplant outcomes were quite poor. Survival was really being measured on a scale of days, weeks, and short months, rather than the many years that we are now quoting our patients. The advent of the ICU ventilator and modern ICUs brought along the need for a new definition of death, brain death, and with that came donation after brain death. And what that allowed for was better donor organ preservation. It allowed the transplant surgeon to assess the cardiac function and viability in situ prior to organ procurement. There was also the advent of modern immunosuppression drugs. So cyclosporin came out in 1983. We had mycophenolate and tacrolimus available in the 1990s. And with these advances, with better recipient selection, better donor selection, that really changed how heart transplantation took off. And as you can see, over the decades, the survival has really improved to well over 10 years and 15 years. And so donation after brain death has been the standard approach for heart transplantation for many decades now. And heart transplantation is the gold standard treatment for end-stage heart failure. And so when we see our patients in clinic, the patients with end-stage heart failure or AHA-ACC stage D heart failure, we're quoting them a median survival of only about 12 months. And this is data from the ISHLT, so the International Society for Heart and Lung Transplant, published in 2025. And as you can see over the eras, with the brown line across the top being the most recent era, the 1 year post-transplant survival is now up to about 92 to 93%. And if you survive that first year, we are now quoting our patients a median long-term survival of close to 15 years. And even within our program, we see some patients who have lived for up to 30 years with their transplanted hearts. So this is a gift that really changed the lives of many patients with heart failure as well as their families. Over the years, you can see that the number of heart transplants has steadily grown. So panel A of this figure represents adult heart transplant recipients between 1992 and 2023. And worldwide, we're now doing over 5,000 heart transplants each year. So what does this look like in Canada? Panel A in this figure is data from 2013 to 2017. The individual bars represent the different provinces, with Ontario in yellow, and the red line across the top is the Canadian-wide data. And on average, there were about 163, 165 adult heart transplants per year. The more sobering statistic, though, is in panel B. So the blue represents patients who are waiting for a heart. The green, unfortunately, represents those who had to be withdrawn from the wait list. Often this was because of clinical deterioration, precluding safe transplant. And the gray bar represents those who died while waiting. So the need for organs continues to be far greater than the availability of donor allografts. And so for this reason, a lot of patients are bridged to transplant with mechanical circulatory support, or MCS. Again, panel A here is ISHLT data representing adult patients from 2005 to 2024. And you can see that over time, more and more patients are being bridged. And now over 50 to 60% are being bridged with MCS. This trend, it was actually initially driven by durable LVAD. So that's the represented in the green bar here. But in recent years, this has been driven a lot more by temporary MCS, so anything beyond a balloon pump, as well as by ECMO. And a lot of this is because in the US, they changed their organ allocation system in 2018 to more highly prioritize those with temporary MCS and ECMO for transplant. But you can see here, there are still about 15 to 25% of patients each year who are being bridged with a durable LVAD. With regard to that, though, not every advanced heart failure patient is a candidate for LVAD for various reasons. And where possible, it is in a way ideal to go direct to transplant to avoid the surgical complications that come with the LVAD. So avoiding that reduced sternotomy, you can get challenges with vasoplegia and early graft dysfunction as well. And so this is a snapshot of Canada in 2024, at the end of 2024. And that year across the country, there were 166 transplants performed. At the end of the year, though, there were still 190 active patients on the wait list. And unfortunately, 13 patients died that year waiting for a heart. The Trillium Gift of Life Network manages organ transplantation in Ontario, and on average, we do about 65 heart transplants across the province. And this is all publicly available data on the Trillium website. This is a snapshot from February 7th, and as you can see, there are about 80 patients right now waiting for a heart transplant in our province alone. Wait times vary. They are influenced by the recipient's urgency on the wait list, but we have some patients, not just in our program, but across the country, who are waiting over 2 years for a heart. And you can see how this becomes a problem when we're quoting them a median survival of about 1 year when they're diagnosed with end-stage heart failure. So what has been done to date to try and expand the donor pool? So the ISHLT does have donor heart selection guidelines. The most recent iteration of this was in 2022. Over time, depending on the urgency of the situation, we have allowed for older donors, so above age 45. We've pushed ischemic time cutoffs. We've accepted hearts with mild LVH and even mild coronary disease, depending on the situation. In Ontario, we also have something called exceptional distribution donors, or EXD. So these are donors who basically flag positive or have unknown responses to certain questions on their medical or social history. So this can include things like cardiac risk factors, whether or not they receive CPR, smoking, alcohol, recreational substances, incarceration, travel history, sexual history. And exceptional distribution hearts are acceptable if there is no other standard organ available at that moment. And in fact, about 80% of the hearts that we accept are EXD hearts. And this is something that the potential recipient does consent to at the time of transplant. There are also now increased risk donors, or IRD. So these are donors who have something on their history that suggests they could be at risk for HIV, Hep B, or Hep C. Now, all the donors are tested, but there could be a window where they haven't seroconverted yet, so you've sort of missed the diagnosis. But we have a protocol in place to accept hepatitis C positive donors. And on call to the OR, essentially, they would be started on prophylaxis, and that's continued for about a week post-transplant, longer if they do have seroconversion. I don't believe we've done one yet at our own center, but we have lots of data from other centers which demonstrate good outcomes with regards to HCV treatment, as well as short-term survival. There are some sort of early concerns about possible increased acute rejection in cardiac allograft vasculopathy, but this is another way in which we have tried to expand the donor pool. And then within our program and in many transplant programs, we routinely review our organ donors. So we try to understand why a potential organ was declined. Was it appropriately done so? Was it accepted by another program? And from that, we learn from our experiences. And through all these methods, we have tried to really get the waitlist moving. And so the big question is, can DCD or donation after circulatory death augment the donor pool? So DCD actually has been performed in Canada since 2006, not for heart, but for kidney, liver, and lung transplants. And it has resulted in the largest increase in deceased donation and transplantation in Canada. And the way it has been performed is after circulatory arrest, the organ is procured and then it's stored in something called static cold storage all the way to the recipient OR. And we have colleagues in the UK and Australia who have been doing DCD heart transplants for actually over a decade now. And I believe the US started in 2019. So what Shemi and colleagues performed here, this was published in 2021. They basically took adult DCD donors in Ontario. So these were donors of other organs, and they applied the protocols that the Papworth group in the UK were using to identify DCD heart donors. And by applying their criteria, what they found was that each year we could have up to 10 to 15 more transplants per year. And for a province that averages about 65 transplants a year, this equates to about a 25% increase in our transplant volume. So why haven't we been doing this? Well, one of the major concerns about DCD have been that naturally withdrawal of life-sustaining measures leads to cardiac arrest. And there have been concerns about using an arrested and ischemic heart for transplantation. We know that ischemic time is associated with worse survival. So this is, again, data from the ISHLT published in 2017. It's a Kaplan-Meier curve representing 6-year survival separated by allograft ischemic times. And so across the top, there's actually overlapping blue and green lines. So the green representing 0 to 2 hours of ischemic time, blue being 2 to 4, and the purple is 4 to 6, and the red is more than 6 hours of ischemic time. And as you can see, the survival curves separate quite dramatically within the first few months, but they do separate, and the survival associated with ischemic time of more than 4 hours is considerably lower than ischemic time of less than or equal to 4 hours. The curves separate early, suggesting that this predominantly affects early outcomes. And this is what's reflected in the ISHLT donor selection guidelines. There's a class 1 indication for targeting a total organ ischemic time for less than or equal to 4 hours. There are also some ethical concerns surrounding DCD. So one of the key rules or principles of transplantation is the dead donor rule. And what this states is that organ retrieval should never be the cause of death of the donor, and the donor must be dead before organ procurement can occur. And this rule always has to be respected. And so within Canada, we have a Canadian definition of death. And I'll just read this off the slide here, but death is defined as the permanent cessation of brain function. So that means that brain function is lost, it will not resume spontaneously, and it will not be restored through intervention. Death determination by circulatory criteria is based on the absence of extracranial circulation that leads to the permanent absence of intracranial circulation or brain circulation. The guidelines also state that permanent cessation of intracranial circulation must be maintained should any postmortem organ donation interventions be deployed. There's one method of doing DCD transplantation known as normothermic regional perfusion, or NRP. And that involves actually restarting the donor circulation in situ by placing the donor onto ECMO or bypass after circulatory arrest. And you do clamp off the aorta branch vessels, but there have been concerns that you can actually get brain reperfusion through spinal collaterals. And so for this reason, we do not do NRP procurement in Canada, not even for the other organs that I mentioned earlier. Some other concerns with DCD is the inability to assess the donor heart viability and function in situ. So unlike in donation after brain death, where organ procurement begins while the heart is still beating, your first visualization of the heart in DCD is after the heart has already been arrested and has gone through a period of warm ischemic time, which I'll go into in a little bit more detail. So this ischemic time increases the risk of ischemia reperfusion injury, and in DCD, you don't get a chance to see the heart before you procure it and place it onto your transport machine. Historically as well, there have also been limitations of static cold storage, but there have been a lot of new advances in organ storage and transportation, which have changed the game and allowed us to do DCD. And so for all those reasons and more, DBD or donation after brain death has been the standard method. And so after declaration of brain death, as I mentioned, organ procurement begins, and it begins while the donor circulation is still intact. And so the transplant surgeon is able to assess the donor heart viability. They can look at how it's functioning before they procure the heart. And this essentially minimizes or eliminates any warm ischemic time that is something you do see a lot of in DCD. So the way the organ is procured is the heart is exsanguinated, it is cooled and stopped with ice slush and cardioplegia. It is then excised from the donor. It's triple bagged, first into a bag of cardioplegia and then 2 bags of saline. And then traditionally, it is then placed into a cooler for transport. And so the cooler looks like the red bag there on the screen. Um, and essentially the heart is placed inside it. It's filled with, the bag itself is filled with ice. And as you can imagine, if you picture it, you have one surface of the heart essentially contacting that ice surface. And the surgeons will actually tell you that when they receive the donor heart, sometimes they can actually feel areas of firmness or freezing injury to the donor organ. So it's not ideal. And so many things have been done to try and deal with this issue. We now have temperature controlled transport, and we also have something called ex vivo perfusion. And the ultimate goal is to try and minimize ischemic injury to the donor heart. And so this is one such temperature controlled transport device. This is the export heart preservation system by a company called Transplantation, which are actually based out of Toronto. So on the left side here, you can see it's essentially a cooler on wheels. So you can wheel this with you from the donor OR to the recipient OR. But the heart is cradled inside a little shelf there, and the entire system is kept to a constant temperature. For this device, it's maintained between 4 to 10 degrees Celsius. And so what the authors here have shown is that the heart stored in the Traferox cooler, they actually have a longer total ischemic time, so 222 minutes compared to 192 minutes, so over half an hour of difference. But despite that longer ischemic time, there were no differences in rates of severe primary graft dysfunction. So this is allowing for a longer travel time and potentially allows you to expand how far away you can accept a donor heart from. The Sherpa pack by a company called Paragonix is another one of these temperature control devices. So this is again, sorry, it's a little bit laggy, but this is again a cooler on wheels. And essentially this machine keeps the temperature between 4 to 8 degrees Celsius. And you'll see shortly, but the heart is again suspended within this box here. So it never has direct contact with any cold surface. It's suspended within a liquid solution that is kept temperature controlled. And you can actually, if you were the person transporting the organ, if you had the app on your phone, it can actually give you real-time temperature data from the cooler. So you can see the heart is suspended within this transport device. And a lot of centers are now actually using this instead of just plain old ice because it has really excellent survival data. So this is 2-year data from the Guardian Heart Registry. So this is industry sponsored, but they looked at the Sherpa pack compared to just plain ice. And the Kaplan-Meier survival curves shown here, you can see that the 2-year survival was significantly higher using the Sherpa pack, 95% compared to 90%. There's also 4-year data here. So again, comparing the Sherpa pack to just ice, and the rates of severe primary graft dysfunction, severe RV dysfunction, the need for placing the recipient onto MCS, such as ECMO post-transplant, these rates are all significantly lower using the Sherpa pack compared to ice. And they were actually able to calculate a number needed to treat of 21 in order to prevent one post-transplant mortality. So this has really changed how organ transportation is done. And a lot of centers, as I mentioned, now use this instead of ice. As you can imagine, though, ice is cheap. So there is a cost associated with this. The per use cost in the States is, I saw quotes anywhere from $9,000 to $17,000 per use. But again, given these changes, maybe it results in cost savings elsewhere, shorter ICU stays if you don't need ECMO, etc. And then finally, we have something called the TransMedics Organ Care System, or ex vivo perfusion. And this is what has allowed us to do DCD in Canada. And so as you can see, the OCS machine, it maintains the donor heart in a warm, beating, and near physiologic state. And so there's many components to the OCS machine, and I refer to this one because this is the one that we will be using to do DCD transplants in Ontario. So the OCS heart console, the console itself is reusable. It has a monitor. It tells you various parameters like temperature, coronary flow rates, aortic pressure, heart rate, O2 sats, and lactate levels. The heart perfusion set is where the organ actually goes into. And this is, as you can imagine, this is single use, it's sterile. And this gets placed onto the heart console machine. The TransMedics company also has this proprietary heart solution. And to this, you add about 1.5 liters of donor blood, which is taken just prior to cross clamp. And this perfusate blood solution is used to prime the OCS circuit. And to this, they add things like epinephrine, heparin, insulin, antibiotics, and methylprednisolone. And so how this works is essentially, if this is your donor heart, the aorta and the pulmonary artery are cannulated. You then fill the, actually don't know if you can see that my mouse, I guess not. You fill the reservoir with that perfusate donor blood mixture, and that gets pumped around the circuit in a pulsatile fashion, and that can be synchronized to the ECG R wave that you can see on the monitor. So that gets pumped through the gas exchanger, so the blood is oxygenated. It gets pumped through a warmer, so it's usually kept around 34 degrees Celsius, and then that goes down retrogradely down the aorta to perfuse the coronary arteries. The blood is then returned via the coronary sinus to the RA, RV, and then out the pulmonary artery, back to the reservoir, and then it keeps cycling through. From this system, actually, I should also mention the LV, it's not shown here, but it is typically also vented for de-airing and to prevent distension. So it's not a truly physiological state, but it is close. And so from the circuit, you can do hourly arterial and venous lactate measurements, more if needed to make further adjustments. And that's the primary way in which you assess whether your donor heart is being adequately perfused throughout the transport. So the venous lactate should always be lower than the arterial lactate so that you know the heart's not actually producing any lactate. And throughout this whole transport time, the lactate value should always be stable or downtrending. So there are some cases where, despite everything you try, the lactate levels will keep rising. And unfortunately, these hearts are typically not transplanted after procurement. And so they first tested the TransMedics OCS device in standard criteria donor donation after brain death hearts. This was the PROCEED 2 trial published in 2015 in Lancet. And they basically compared the OCS system to just standard cold storage with ice. So they did not find any significant difference in 30-day patient survival, 30-day graft survival, their secondary endpoints, cardiac-related serious adverse events, incidence of severe rejection, and median ICU length of stay, no significant difference. So what's the point of this expensive machine? The point is that you can keep the cold ischemic time within a very reasonable range while prolonging the overall preservation time of the donor heart. So as you can see in the top left in figure 4, you always have a period of cold ischemic time before the organ is placed onto the machine. Then you have that period of machine perfusion time. And then when you get to the recipient OR, you rearrest the heart with cardioplegia, and there's a period of cold ischemic time that starts there until release of the cross clamp in the recipient OR. In the bottom right, though, you can see that the total preservation time, while it is significantly longer using the OCS, the actual cold ischemic time is significantly shorter compared to just using ice. And so in the era of donation after brain death, this was very promising for use in long distance procurements. And, within our program and many other transplant programs, it is not uncommon for us to have to decline potential donor hearts because of concerns with travel time, ischemic time. And so the Transmedics OCS is a way to address that. And so this is data from the OCS Heart Perfusion Registry. It was published in Circulation just last year. And what they found was that 6-month survival and 12-month survival between OCS donation after brain death or just cold storage donation after brain death, there was no significant difference. I should mention here that the cold storage here was a combination of both ice and use of temperature controlled transports like the Sherpa pack. Um, but again, no significant difference in the outcomes. However, what they found was that the OCS hearts were traveling something like 670 miles in the States compared to 230 miles with just using the standard cold transport. So you have the ability now to expand your geographic donor access while maintaining equivalent outcomes. And this ability to perfuse the heart during transport using the OCS machine is what's allowing us to do DCD here in Ontario. And we do DCD using something called the direct procurement and perfusion method. So I'll focus in on the bottom half of this figure and go through what DCD actually looks like. So, as with all organ transplants, it starts unfortunately with a potential donor who has had a catastrophic injury. They don't quite meet criteria for brain death, but they are not expected to have a meaningful neurological recovery based on their care team's assessment. So, based on their previously stated wishes or their substitute decision maker decision, they undergo withdrawal of life support. And it should be very important that this decision to withdraw life support, this should always be made before there's even any question of them becoming a potential organ donor. And that's very clearly laid out in the ISHLT position statement on DCD. So there should be an absolute distinction between the team providing patient care, the team providing withdrawal of life support, and the organ retrieval team or the procurement team. And it's really important that the potential donor has appropriate comfort care measures throughout any part of the process that is related to organ donation. So, for example, we often will ask for an echo as well as a cardiac angiogram if we feel that's necessary to assess the potential donor heart. So, the potential donor has to be kept comfortable throughout any of these procedures. And the procurement team really only becomes involved after certification of death occurs. And so one of the big things that we care about in donation after circulatory death is something called functional warm ischemic time. So this this timer starts when the agonal phase starts. And the agonal phase has lots of different definitions depending on what country or program you look at. But it's typically the period of time when the systolic blood pressure drops below a certain threshold. Um, and when the O2 sats drop below a certain threshold, usually 70 to 80%. And so this functional warm ischemic time begins at the agonal phase, and it lasts until cross clamp is placed on the donor aorta. And so these are different protocols from various centers around the world. So the St. Vincent's group in Australia and the Papworth group in Australia in the UK were some of the first programs to do DCD heart transplants. They have slightly different definitions of the agonal phase and when functional warm ischemic time starts. So Australia uses a systolic blood pressure of less than 90 minutes. The UK uses systolic blood pressure of less than 50 millimeters of mercury. But as you can see, they both keep to a functional warm ischemic time of less than 30 minutes. And the reason for that is we do have good data showing that outcomes are optimal if the functional warm ischemic time is less than 30 minutes. The hearts are expected to fully recover from that period of warm ischemic time. And in some cases where the functional warm ischemic time extends beyond 30 minutes, then unfortunately the hearts are actually not procured. And so throughout this whole process, the donor's blood pressure is monitored, and this is typically done using an invasive arterial line. So within our Canadian guidelines, we define circulatory arrest as an arterial pulse pressure of less than or equal to 5 millimeters of mercury. And they use this because the systems below that threshold, the ability to actually monitor the pulse pressure is not very well, is not actually done well. So they just picked this 5 millimeter mercury cutoff. But what we know is that beyond this, below this 5 millimeter mercury cutoff, once that has been going on for more than 1 minute, that is not associated with resumption of circulatory function throughout the standoff time. And so once circulatory arrest is seen, there is something called standoff time. And this is a mandatory period of time where no interventions are allowed, or no interventions are allowed. So the patient is observed throughout this period of time. It is used to confirm permanent cessation of circulation. The Canadian guidelines and the ISHLT guidelines advise a 5-minute standoff period for controlled donations. So controlled donations being planned withdrawal of life support. And this 5-minute cutoff time actually comes from a Canadian study that was published in the New England Journal of Medicine in 2021. So it's a group of ICU doctors who looked at over 630 patients undergoing withdrawal of life-sustaining measure. And so they looked at how long after pulselessness could you potentially have spontaneous resumption of cardiac activity. And the longest period they found was 4 minutes and 20 seconds. So they then picked the 5-minute cutoff time for this period of standoff time. But as you can see, that can be as short as 2 minutes in Australia and the US, and as long as 20 minutes in Italy and 30 minutes in Russia. But we are using a 5-minute cutoff time. So once this mandatory standoff time is completed, that is when death is officially declared. In cases of organ donation, you actually require 2 physicians to make this determination. Neither of them can be involved in any way with the transplant process, so they can't be involved in organ allocation. They cannot be involved in the care of the potential transplant recipient. And once death is declared, that is when the organ procurement team comes in. As I mentioned, just prior to cross clamp, actually, you do need to obtain about 1.5 liters of donor blood to perfuse the TransMedics OCS system. And then I'll go into more detail on what direct procurement and perfusion looks like, because that's the method that is acceptable within our Canadian definition of death. And that's how we would be doing DCD heart transplants. And so on the left side of each figure is the direct procurement and perfusion method. So again, once you obtain your donor blood, you then cross clamp, you do cold cardioplegia flush, and you procure your organ. And this time is actually cold ischemic time. And it's cold ischemic time until you cannulate your organ onto the OCS machine and start up the perfusion on the machine. The heart is then perfused throughout transport. So again, you're monitoring the lactates, you're monitoring the coronary flow rates. You can visually inspect the heart after it's been restarted on the OCS machine. You can even do echo if you wanted, but there are different ways in which to assess whether the heart appears to be viable and functioning well. And it's kept on this machine perfusion all throughout transport until you reach the recipient OR. At that point, the heart is then rearrested. So the machine perfusion time ends. You get the start of another period of cold ischemic time. And the heart is rearrested and then placed into the recipient. And that cold ischemic time ends when the recipient cross clamp is released. I'll briefly touch upon NRP. So on the right side of each figure, NRP, again, it's not the way we would be doing DCD heart transplantation. But essentially, as you can see, after standoff time and death declaration, sternotomy is performed and the aortic arch vessels are clamped off to try and prevent any brain circulation from occurring. The donor is then placed onto ECMO or cardiopulmonary bypass, and this allows a period of time to watch for the heart to restart, to see how it's functioning, to watch and make sure that it recovers from that period of warm ischemic time during the withdrawal of life support measures. During this time, you can do things like TEE, you can put a Swan-Ganz catheter in, and if the transplant surgeons are satisfied with everything, that is when they do arrest the heart, do their cold cardioplegia, and procure the heart for transport. Often this is actually done using temperature control transport, but you could in theory use this with the machine perfusion as well. Typically though, the thought with NRP is that it's overall cheaper because you're using pre-existing ECMO or bypass equipment that the transplant center already has. And this temperature controlled cold storage is cheaper than using the OCS machine. And so this landmark trial in New England Journal of Medicine in 2023 by Schroeder and colleagues, they essentially compared DCD heart transplantations using the OCS machine compared to donation after brain death hearts using ice storage. And what they found was that they looked at 80 patients who received a DCD heart compared to 86 patients who received a DBD heart. And the risk-adjusted 6-month survival was 94% in the DCD group compared to 90% in the DBD group. So significant for non-inferiority. They also did not find any substantial differences between the two groups in terms of serious adverse events. So the outcomes are comparable. Many centers across the world have published their DCD outcome data. And so Zong and colleagues did a meta-analysis of 12 studies across the UK, Australia, US, Belgium, and Spain. And these studies all looked at DCD versus DBD. And what they found was that the donation after circulatory death heart transplants were associated with a lower 1-year and 5-year mortality rates. They did say that this might have been helped because the DCD donors tended to be younger. The DCD recipients also tended to be less urgent on the transplant waitlist, but this early outcome data is quite promising. This is data from the Transmedics OCS registry, and this is comparing OCS supported DCD compared to static cold storage DBD. So this again could have been ice or using temperature controlled storage like the Sherpa pack. It's probably a good mix of two because as I mentioned, ice is not really the way to go anymore. And what they found from the registry was that the 6-month and 12-month survival again were similar between the two groups. So what about things like post-transplant complications? So primary graft dysfunction or PGD, this is something we always worry about, and it's defined as severe cardiac dysfunction, which occurs within the first 24 to 72 hours post-transplant. It cannot be because of hyperacute rejection. It can't be due to surgical complications like tamponade or bleeding. It cannot be due to sepsis or severe PH, for example. And the rates of this, it varies quite a lot within the literature. I've seen anywhere from 6% to as high as 41%. But regardless, it does not appear to be associated with any sort of increase in long-term mortality. And so that same Transmedics paper by Schroeder and colleagues, what they found was that the rates of primary, moderate or severe primary graft dysfunction was much higher in the DCD group, something like 22% compared to just 10% in the DBD group. But again, as I mentioned, they did not find a significant difference in terms of 6-month or 1-year mortality. But the thought is that this increased rate of PGD may be associated with that period of warm ischemic time while you wait for withdrawal of life support measures to be completed. This is the same transplantation meta-analysis from 2024. And what they found was that, again, there is a trend towards increased risk of PGD in donation after circulatory death, although they did not find a significant difference. It does seem like, however, over time within the literature, the rates of PGD are actually decreasing. That's likely just due to experience, better donor selection, and better perioperative management. This is more recent data from September 2023 to June 2024. So Cho and colleagues looked at transplants in the US during this period of time. And again, what they found was that severe PGD rates at 24 hours was much higher in the DCD recipients compared to the DBD recipients. But they found that this graft dysfunction actually improved by 72 hours. And the 72-hour severe graft dysfunction rates were similar between the two groups, as well as the 30-day mortality. In terms of breaking down the different ways of doing DCD, I think we need a little bit more data. It's possible that the direct procurement and perfusion method, like the way that we would be doing it, is associated with a little bit more PGD than the NRP or ECMO method. Their thought is that it's possible that with this longer sort of preservation time with the machine transport, that could be contributing. But they also found that a lot of times the direct procurement and perfusion method recipients tended to actually be sicker. So they were actually more likely to be on pre-transplant inotropic support. So we're not really sure for the moment. I think we'll have to wait and see what the future data tells us on the two different ways of doing DCD. So what about ICU admissions and hospital length of stay? So the early data tells us that there's no significant difference between the duration of ICU and hospital admissions. And with regards to acute rejection, there does seem to be a trend towards the increase, a trend towards increase in acute rejection in DCD. This does not appear to be significant in most studies. And this study here by Luca and colleague, they looked at global data and they weren't really sure why they were seeing more rejection in the direct procurement and perfusion method compared to the NRP method. The two groups are actually quite similar in terms of recipient sensitization or donor-specific antibody formation. So I think we need a little bit more research to figure out why the rates of acute rejection seem to be higher in DCD and with DPP. CAV or cardiac allograft vasculopathy is also something we worry about in our transplant recipients. So this is a key challenge in long-term management of our patients. CAV is a major cause of late graft failure. It's a major cause of mortality beyond that first post-transplant year. And there have been concerns that the warm ischemic time can exacerbate a lot of immune-mediated injury and endothelial dysfunction, both of which are implicated in the development of CAV. This is a systematic review and meta-analysis by Safdar and colleagues that was published just this year. And what they found was that the rates of 1-year CAV incidence were similar between DCD compared to DBD. And 1-year mortality, again, was also similar between the two groups. Breaking down the different ways of doing DCD, what they actually found was that the direct procurement and perfusion methods, so the TransMedics OCS method, may actually be slightly better than your classic donation after brain death. That being said, what they found within their population was that the donation after brain death recipients tended to be more ill at baseline, so it's possible they mounted less of an immune response that gets implicated in the formation of CAV. In the two ways of doing DCD, the DPP method appeared to be significantly better than the NRP method for CAV at the 1-year mark. The authors found that these two groups are actually similar at baseline, and they proposed that it's possible that by restarting the donor circulation on ECMO in the normothermic reperfusion method, that might actually trigger immunologic changes within the donor themselves, and the donor heart then gets exposed to this. Whereas if you're using the ex vivo perfusion or the OCS machine, the organ, as you know, is explanted before perfusion, so there's no interaction between the heart and the donor's own immune system. But again, we need a lot of further research to better understand how warm ischemic time or cold ischemic time, how differences in those durations affect the development of CAV. And so between the two DCD strategies, the optimal recovery strategy is not clear to date. So Luca and colleagues, they looked at 22 heart transplant centers globally, and this included a total of 504 DCD heart transplants during that study period. The survival at 1 year was similar between the normothermic reperfusion method and the direct procurement and perfusion method. So no significant difference in short to medium term survival in the studies to date. But again, as I mentioned, there are ethical concerns with NRP, so we're not doing that within our program or within Canada. But what DPP did allow for was longer travel time and further distance traveled. So this is a map of the US, and you can see that the DPP organs in blue were transported across a much greater distance, so 460 nautical miles compared to the NRP cold storage organs with 273 miles. So this has really allowed us to expand the donor pool, expand geographic access. And it's also just important to touch upon rejected organs. So in DBD, sometimes DBD hearts are not recovered because of persistent cardiac dysfunction or hemodynamic instability during the procurement process. Sometimes after sternotomy, you also discover things that abnormalities that were not seen on the pre-transplant imaging. And so usually about 3 to 4% of DBD hearts are not recovered after the sternotomy. And of hearts that are recovered, about 1% of DBD hearts are not utilized. These rates are actually significantly higher in DCD. So DCD hearts were about 10% of them are not recovered after evaluation. And about 7 to 8% are actually not utilized after recovery. So reasons for this include, again, failure to progress to circulatory death within a certain time frame. So your functional warm ischemic time has gone beyond the 30-minute mark. Sometimes you can have issues cannulating the heart onto the OCS machine. So I read about one case where they actually realized after the fact that the donor had connective tissue disease and the aorta essentially disintegrated and they couldn't cannulate it onto the machine. You can have issues with thrombus, issues with inadequate donor blood collection. If you're monitoring the heart on OCS, you can have concerns for poor function or viability, and likewise on ECMO as well, poor organ function or issues with reperfusion. The NRP method may be slightly better in terms of organ recovery and utilization. Because you have that time on ECMO to watch and wait for the heart recover, for the heart to recover, you just have more time to do your assessment. You're not as rushed to do your organ retrieval. And so the NRP method may be slightly better for heart recovery and utilization. And then in terms of cost, as I mentioned, the TransMedics OCS machine is expensive. I don't have the Canadian numbers, but in the US, the console itself costs $275,000 upfront. And then the single-use components, the sterile components, cost anywhere from $38,000 to $55,000 per use. So there is a significant cost associated. As I mentioned, NRP tends to be less expensive. You're using pre-existing ECMO machine at your transplant center. The static cold storage, even if you're using, say, the Sherpa pack, that's still less expensive than the OCS devices. But this has made a big difference on our transplant volume. So this is data from the United States, and what they found was that donation after circulatory death decreases waitlist mortality. So fewer patients were being delisted because of death or deterioration. And the post-transplant survival, again, was similar between DCD and DBD. They also found that the waitlist time was a lot shorter in DCD recipients, even if they were not as urgent within their ranking system compared to donation after brain death. So DCD does improve transplant volumes. And so in conclusion, heart transplantation is the gold standard for end-stage heart failure. It has transformed the lives of many patients and families. And despite everything we've tried to expand the donor pool, there continue to be long wait lists, and we still see patients get delisted or pass away while waiting for their heart. So what DC has done is it has expanded the donor pool, it has decreased waitlist mortality, and the global data, at least for short and medium term outcomes, are quite excellent. So as with any new procedure and process, there's always a learning curve. We have the benefit of learning from all these other centers and countries that have been doing heart transplants for over a decade now. And hopefully we'll be doing one of our own soon. DCD heart transplantation has been live in Ontario since the end of January this year. And so I want to say thank you to everyone for coming today. I also want to thank the heart failure and transplant team. Special thanks to Dr. McGinty for her mentorship, to our heart transplant coordinator, Kyla, for answering all of my questions for this presentation, and to Dr. Toeg as well for his help with this presentation. And I'll just leave you with some final thoughts here. Organ donation is, of course, a very personal decision, but it's something I encourage you to think about and talk about with your loved ones if you haven't yet had that discussion. Beadonor.ca has a lot of information on how to register if you are interested. So thank you.
Albert, Annie, thank you so much. This was great. I just have a question from like a physiology point of view. OCS is very interesting and thank you for enlightening me a lot. Many things that I didn't know. So if you're putting a cannula in the LV for these patients to went out there, the OCS system, you're giving a receptor, an LV with a scar, right, in the future. Do you have any information of ventricular tachycardia, mid, long-term probably this is to you, I don't know, because that's kind of a little bit of the price you have to pay up. Remember that scar means so straight means arrhythmias in the future is ventricular tachycardia coming from the LV. So any thoughts about that?
Yeah, that's a really great question. Thanks, Pipe. I didn't actually see that data in the papers that I went through for the presentation. In terms of the de-airing, like the vent, they typically do this as part of the transplant process anyway in terms of DBD. So I'm not sure if between the two groups there would be any difference, but I didn't actually find that in the papers that I looked at, whether that was a big issue post transplant.
Great job, Amy. That was excellent. Thank you for doing that. My question is just about if there's any literature or anyone who's published anything about heart transplant, like donation after MAID.
Yeah, that's a really good question. I'm not sure if we are doing that in Canada. I know it is legal. We certainly do transplants post-MAID for things like lung, kidney, and liver, although I think some of the outcomes suggest the liver transplants are not as excellent if the cause of death is MAID. I know there is data out of Belgium, I think, in some of the European countries that have done heart transplants after MAID, but I think it's just like a few cases rather than a lot to really understand how that might affect outcomes. There is a thought, though, that with MAID, your withdrawal of, well, that period of warm ischemic time is actually quite short because you're almost causing instantaneous arrest. So it's possible that your short ischemic time leads to better outcomes, but I don't actually have any published data to back that up.
Thank you very much.
Everyone.